So let me just introduce myself. I'm Susan Harrison. I've had a number of connections with Lambeth over the years, and I was very privileged but also very sad to be asked in probably about 8 years ago to review the circumstances of a man who had been rough sleeping in Lambeth and died on the street in the winter of 2010. He had had a lot of contact with services, but at the point of his death, sadly, he was sleeping rough in West Norwood. But more generally, I've worked in health and homelessness at various different times. I retired a couple of years ago, and when COVID arrived and changed our lives, I was invited to go back into working in the NHS, and I'm actually working in health and homelessness again. So I'm hoping that that background will be useful. But moving on then to a little bit about what this session is going to include. I'm going to give you quite a bit of data about homelessness per se. There's lots of numbers, and you will, I guess, want to look at them later. I won't be going through them line by line. I will be talking a little bit about the legislation that supports our practice, often a challenge to make use of that when we're out on the front line advocating on behalf of people who are homeless, but we do have a lot of legislation that is supportive in terms of helping people be safer when they're in housing need. I'm also going to talk a little bit about the research evidence and the practice evidence that has been built up over some time. So we're not having to reinvent the wheel. We can go back to good practice and best practice that other people have developed. I'm also going to just talk a little bit about what's happened during the pandemic, because some very interesting things have happened that have helped people be much safer, people with housing need, and I'll talk a bit about that. As I've said, there are quite a lot of links to resources, and as a follow-on from attending today, you'll get my slides, but you'll also get a couple of key briefing documents about the serious case review. It was called a serious case review because it was before the Care Act was in place in relation to Mr. A. And then the Safeguarding Adults review relating to Yi, and I'm going to talk a little bit about that. So that's the outline. A little reminder as we start about some absolutely key issues that are a bit kind of common sense. What is it that helps people who are homeless be safe or safer? And of course, the absolutely most important thing is safe and secure housing. And those of us that are fortunate enough to have it, take it for granted. And when we haven't had it, we know how very difficult our lives can become. And income, whether it's through benefits or through employment, is also a key plank in helping us keep safe. Healthcare, likewise. And of course, in this country, we have so much better access to healthcare than perhaps in other parts of the world. But I'll say a little bit about people in the UK who have less access to healthcare. And then our connections with others, with our friends and family, with the people that we value. And of course, sometimes we might not think our family are our best resource, but we may have friends who give us comfort and connection. And then, of course, remembering that when adults who are responsible for children don't have those secure bases, then the well-being of children is put at risk at a very early stage and may impact on their well-being over many years throughout their lives. And when we're out on the front line, it sometimes seems almost impossible to broker some of those things for the people that we serve. The policy and political context that we live and work in is very challenging for some people. And it's especially challenging for people who are non-UK citizens, who have no recourse to public funds, whose immigration status means that they're not entitled to housing, or they may not work, or if they aren't currently working, then they have no income. And there are some restrictions on access to health services for people who are non-UK citizens, and that presents a challenge to supporting people to be safe. A little slide here about the complexity of the experience of homelessness. It's a slide that was developed by my colleague Jill Taylor in Haringey, so thanking her for this slide. So the circumstances that lead people to become homeless are sometimes very individual: a relationship breakup, a period of ill health when people aren't able to work. But there are also issues always about local systems. Are people able to find their way back into getting support? Excuse me, and much bigger structural and social issues. So when it comes to individuals, there's issues of health. There might be issues of bereavement, a loss of an important relationship. When it comes to local systems, there might be the ways in which housing and hostels work locally, the way that the police work locally, access that people have to housing. And then we have the much bigger national issues, which are about welfare policy, immigration policy, austerity policies. So just remembering all of that is an important thing when we're engaged with people who might be at risk of homelessness or who are homeless. The solutions are sometimes personal, sometimes they're about local services, and sometimes they're about national policies, and often all those things interact. I'd like to introduce you to a term which you may or may not be familiar with, which is multiple exclusion homelessness. So when all those things that I showed on the previous slide come together, then the experience of homelessness can drive you out of connection with your nearest and dearest, but also out of connection with society. And then your experience of marginalisation can be really acute, because you may have a history of childhood difficulties, but now you may have some physical and mental health issues. You may have substance misuse issues, which could have started before, but equally, if you're living in very precarious circumstances, drowning your sorrows is an absolutely understandable choice to make. When those things come together, then the experience is extremely difficult for individuals. And the experience of being physically unwell or mentally unwell can lead to new challenges. So fights often lead to acquired brain injury, which then fights or tumbles or falls or road traffic accidents, leading to cognitive impairments that actually make the situation worse. And as providers of services, we sometimes don't bear all of that in mind when we try to engage with people, when we try to organise appointments, when we try to convene people in events. We respond to individuals as if they were able to make sense of letters, or actually receive letters if they're living on the street. So our practice needs to be really deeply informed by the lived reality of people who have multiple exclusion homelessness characteristics. I'm going to say a little bit more about that as I go through, but this particular slide is one that Professor Michael Preston-Shute uses, and it builds on work that he's done with a third sector organisation called the Voices of Stoke. So a little bit about that term that I used or is referenced in the slide about trimorbidity. Again, lots of detail here, but at the most precarious end of rough sleeping, the prevalence of substance misuse, mental health issues and physical health issues all come together into an experience of what clinicians call trimorbidity. So all three aspects of ill health coming together. And certain aspects of physical health are much more prevalent in our rough sleeping population. So, for example, tuberculosis, 34 times higher in the rough sleeping population. And I'm going to say a little bit about COVID because we have a slightly different story there. But COPD, so respiratory illness that's chronic and has built up over a length of time, is 13 times more prevalent in the rough sleeping population. So lots of references there, and this is a slide that the Healthy London Partnership, the clinical lead there, Dr. Caroline Schulman, has developed to tell the story at this time. So a little bit about what we know about London and what we know about homelessness in England. Crisis, the third sector organisation that work with homeless people, produced a report some years back that, and this has been confirmed with subsequent statistical work that the Office for National Statistics have done, that show that the experience of homelessness is likely to lead you to die in your 40s, and that's across all types of homelessness. So, all being well, as a citizen with good health, I would expect to live into my 80s. If I have a significant history of homelessness, sadly, my life expectancy is much shortened, and the average age of death is in mid-40s. In London, in the last year, there were 131 different nationalities recorded of individuals living on the street. So a very diverse population. And last year, almost 11,000 people were seen sleeping rough in London. That's not on any given night, it's over the course of a year. And that's a big surge. It's a big surge, and I'll talk a bit more about COVID. In the previous year, there were about 9,000, so there was a jump, and that's because more people appeared as the pandemic took hold. But that's the tip of an iceberg. The London Assembly that is part of the Greater London Authority, is a kind of political scrutiny challenge group, conducted a piece of work a couple of years ago where they estimated that there are 13 more times people who are hidden homeless than the rough sleeping population who are more visible. And the number of rough sleepers in London has gone up more than twice, so 2.5 times in the last 10 years. And that's as a result of housing and austerity policies and immigration policies. Lots of different statistics are available about the use of hospital services by homeless people. But to give you an example of that, people who are homeless use hospital services much more frequently, so 4 times in this particular statistic. So lots of data there. There's a very detailed report that Crisis produced jointly with Joseph Rowntree, and it's well worth looking at if you want to really dive into the detail. So a little bit about Lambeth now. So in common with London, the number of people sleeping on the street in Lambeth spiked at the end of 2019-20. So it was 130% of the previous year. And that's directly to do with the trend that was going up anyway, but what happened as the pandemic became evident. And as you'll see there, the issue of needs is significant. So lots of substance misuse needs and mental health support needs. But very interestingly, and this is true in London as well, a proportion of people who have no apparent support needs. And what we've seen during the COVID period is that people in the gig economy who are working in construction or in the hospitality industry, people who've got lots of wherewithal to engage with the world, but having ended up without income, have ended up on the street. And so the best route for them is employment back into being able to manage their living circumstances. And again in common with London, about half the people sleeping rough in Lambeth were people who were non-UK citizens. And Lambeth responds by commissioning a range of different support services. So they're listed there, and colleagues from Lambeth will be on the panel discussion later. And in particular, approximately 450 beds in the hostel pathway that support people who have been rough sleeping and who are single and homeless. So I'm just going to canter through quite quickly about some of the things that have happened during the pandemic. As it became clear the extent of what the pandemic might mean for England, the Ministry of Housing, Communities and Local Government were lobbied and then engaged with some key actions. So one of the key actions was that they have funded accommodation for rough sleepers. And I'm going to say a little bit more about that. But in London, 7,000 people who were either rough sleeping or very close to rough sleeping have come into living in hotels. A fantastic intervention to help people be safe and safer. Also nationally, winter night shelters, I mean, it was just the tail end of winter, but night shelters have been closed. It's impossible to run a night shelter and keep the right level of infection control, infection prevention and control, and social distancing. And a lot of effort was put in to support people to be discharged safely from hospital. Prior to that, sadly, even though it wasn't policy, it wasn't unusual for people to be discharged after a hospital admission to the street. And Pan London, the NHS commissioned, the NHS and Public Health commissioned outreach COVID testing and Pan London drug and alcohol services. The hotels that were set up in London also established what was called COVID Protect facilities for people who were in the broad shielding category, and COVID care facilities for people who were symptomatic and couldn't self-isolate. And the NHS in London is divided into integrated care systems. They used to be called STPs. And they are working very closely with their local authority colleagues to support those 7,000 people who are in the process of being rehoused. Lambeth locally did something very similar. So additional bed spaces for rough sleepers, additional bed spaces for people with no recourse to public funds, and the Ministry of Housing, Communities and Local Government also suspended some of the requirements that restricted their access to services. You'll also see that 91 people were in the broad shielding category, and they have been provided with additional wraparound support. And Lambeth has been working very closely with the outreach testing service to make sure that people were getting the testing that they needed when they needed it. A very busy slide here, but you'll have this in your pack. The chief executives of councils and the housing directors are monitoring every week the movement of people off the street into hotels and into accommodation. So lots of detail there, but you can have confidence that that is being monitored every single week. And looking at it in a sub-regional way as well. So if we think about Lambeth, which is in the southeast of London, in the totality of the southeast region, which is Lambeth, Southwark and Lewisham, Bromley, Bexley and Greenwich, there are 514 people who are in the process of being rehoused. Actually, I'm going to go back to my previous slide just to alert you to the fact that there are about 900 people actually on the street. So not everybody has come in. There are some people who declined to come into hotels, and sadly we're seeing new people arriving on the street. So people whose economic circumstances have changed and are now living on the street. And the hotel rooms are more difficult to access now. And that is presenting us with a bit of a worry in terms of, as a second surge starts to develop, how the Ministry of Housing, Communities and Local Government will respond to funding more hotel accommodation. So going back to the complexity of engaging with this issue, engaging with individuals, but engaging with the policy context, what research tells us is that if we want to be doing the best by people who are homeless and living on the street in terms of their safeguarding needs and their ability to be safe, so safeguarding in the broadest sense, but also just being safe, we have to think about the adult, we have to think the individual, the context in which they find themselves, the organisations that they link up with, how the professionals work together. So in her introduction, Shan really emphasised the importance of multi-agency, multidisciplinary working, and then how that's governed, how that's overseen by the Safeguarding Adults Board. And then finally, how the national legal policy and financial context impacts on all of that. And the challenge when you're a practitioner down on the front line is that you're very close to the individual with needs and you advocate strongly, but you also know that there's a much more complicated picture over which you may or may not have some control. Often as frontline practitioners we don't, and yet it's highly relevant to the needs of the individual. So just another way of explaining how all those things link together. And this is a diagram from Michael Preston-Shute, Professor Michael Preston-Shute. I'll talk a bit more about some work that he's led with others that's also a very useful resource. So here it is. About a year ago, the Local Government Association commissioned or held 4 workshops. They were held nationally, and they resulted in a really important resource pack. The link is there, it's on the Local Government Association website, but as part of your pack for today, you'll get the slides, you'll get that pack, you'll get that toolkit. In the graphic that I just showed you, that one, is referenced in that pack, and I've just spelt it out there in words as well. I also just want to draw your attention to another more academic publication. Sadly, when people die, and we've talked a little bit in the introduction about Lambeth reviewing the circumstances of the death of 2 different rough sleepers, localities, the Safeguarding Adults Boards can commission a review of the circumstances of the care and the death of those individuals, or the very serious incident is sometimes not a death necessarily. There's an academic paper which summarises the learning from all those Safeguarding Adults reviews. So if you have a bit of time and you're working on your own professional development portfolio, that's really worth having a look at, because it tells a very poignant but broad story with some key themes. Now, I want to just talk a little bit now about a particular review that Lambeth commissioned. Lambeth commissioned it along with 3 other Safeguarding Adults boards in London. Yi, who was a man who had a very significant history of rough sleeping, but also had owned a house at a point in time, was moving around in London across a number of different services, had been identified as having care and support needs, had been the victim of assault at times, had experienced neglect, had issues to do with his mental health and his mental capacity. So lots of different needs interacting, and at a point in time was admitted to hospital and was then able to be accommodated safely, but sadly died shortly afterwards. And in a very important way, 4 Safeguarding Adults boards came together to say, when we look at the life that this man lived and the suffering that he must have had, what can we learn? Because it's just what we wouldn't want for ourselves, what we wouldn't want for our loved ones, what we wouldn't love for our community, want for our communities. How do we implement change that would help individuals? So it's a very detailed review. You can access information about the review on the Lambeth Safeguarding Adults website, which the link is in the pack later. And as part of the handout from this session, we're going to give you a little summary of the key issues that were identified in this very important Safeguarding Adult review. We're also going to give you a summary of the review that I did, which is now some time ago, of Mr. A. So Mr. A died on the streets in the winter in 2010. So these stories are poignant, they're sad, they make us very angry, and they should make us very angry when we read them, because when we look back with the benefit of 2020 hindsight, we can see how things might have been different. And sadly for those individuals, they weren't. And our duty as public servants is to do our utmost to enable those events not to be replicated for people now. Now, I want to just move briefly now to reflect a bit on, if we were to ask people who are homeless, does safeguarding work well for you? What would you want from safeguarding? So if we get into thinking a bit about making safeguarding personal, regrettably, we don't always ask people who are homeless what they think about safeguarding. But when we have, and colleagues in Lambeth have, so about 3 years ago I was involved in commissioning a focus group from a third sector organisation in Lambeth who was working with rough sleepers. They tell us it's very, very difficult to get help from social services or housing. And it's especially difficult if you're a person without recourse to public funds. They also tell us that homeless people are often victims of the cuts in health and social services and housing. They tell us that sometimes homeless services can be chaotic. And sadly, they tell us that sometimes staff in homeless services don't treat you with dignity and respect. And that's hard to hear, but we also know that it's true. The circumstances of Mr. A and his experience of living in precarious circumstances was that it was alleged at a point in time that his housing support worker had fraudulently accessed his benefits. So a poignant set of circumstances that resulted in him not being able to pay his rent led then to his eviction. So really tragic that had happened, because if you tracked back over time, you could see how an intervention at that point might have really kept him so much safer. So a challenge for all of us. And related to that, issues with the training of staff in relation to safeguarding and homelessness. The importance of peer advocates was something that this particular focus group raised. So having people who were formerly homeless to provide a bit of advocacy, really, really important. And, whoops, sorry, knocked my screen there. We also asked some staff what they've understood about safeguarding and homelessness. And these were staff who were working in homelessness organisations of one kind or other. And they also told us it was often difficult. And they quoted, which I'm sure many of you will have heard in your work as well, that the choice that people deciding to live on the street is a lifestyle choice. Now, that feels such an insult, but it's commonly quoted. Frontline housing support staff also told us that sadly in some localities police were less engaged with the lived experience of people living on the street and not willing to follow up on safeguarding issues. And I guess also something that many of you might be familiar with, when a frontline practitioner was trying to find a way through the system, people told us about practitioners passing the buck, passing the responsibility on to other services and not stepping in to respond in the moment. So the concept of no wrong door is really important here. If somebody steps forward to say, I'm working with somebody who's sleeping rough and I don't know what to do and I need some help, actually my responsibility as a practitioner is to try and be really helpful. Of course, signpost to where that help can be made available, but not say it's nothing to do with me, go away, find somebody else. I mean, perhaps people aren't that crude in the moment, but the experience of frontline staff is that sometimes it feels a bit like that. If you want to know more about the experience of people who've been sleeping rough and people who are homeless during COVID, Groundswell, who are a third sector organisation, have been doing a significant amount of work. They've been commissioned by NHS England to provide summaries and reports of the lived experience of homeless people, so really worth looking at. Just a little bit of talk and chalk, belt and braces content about what's important when assessing and supporting people in need. So back to the theme of making safeguarding personal. It's really so central to be, as best we can, coming alongside individuals and responding to how they see the help that they need. Focusing, of course, on their assets. Our assessment tools often are very deficit focused, and there's all sorts of reasons for that. But people who have an experience of living on the street have often developed lots of skills and lots of abilities, and of course have a whole life history behind them as well. Psychologically informed approaches, you may know a little bit about this, it's sometimes called PI. People who have a history of homelessness have very good reasons to mistrust other people. And why wouldn't they mistrust me as a frontline practitioner? So thinking about that and learning about the ways in which we can come alongside people that recognise the trauma that might be part of their lives is really important. And then the needs of non-UK citizens are a really tricky policy conundrum. The benefit that we have during COVID is that responding to their COVID needs is absolutely permitted in the legislation. And providing them with health support for COVID is completely permitted. And there's no restriction whatsoever to that. But of course, access to other things may be more limited. And again, one of the challenges in terms of being personal, in terms of the approach to helping people be safe, is to really think about innovation. What can we do that will help people be as safe as possible, responding to their needs, but in an innovative way as possible, thinking about the kind of care and support packages that might be a little bit out of the ordinary, but actually really help people. Again, just emphasising the need for working together with others, trusting other people's assessments, and really listening very carefully to issues of mental capacity. I'm going to say a little bit more about that when I come on to the law. So here we are on the law. Lots of different bits of the law that support us. Various bits of the Care Act, various bits of housing legislation, the Mental Health Act, the Mental Capacity Act, the Equality Act, and the Human Rights Act. And of course, adults who are homeless may be looking after children who are homeless, and therefore all the children's legislation becomes relevant, as it does for 16 and 17-year-olds. So as a frontline practitioner, it might be a bit daunting, it might feel a bit daunting to know where the levers are in each of those bits of legislation. But working closely with law centres or advocates who do understand them is an important contribution to the lives of individuals, because ignoring the needs of somebody who isn't safe and who is at risk, who has both safeguarding needs and housing needs, might well mean that any of us are in breach of a whole range of different elements of those bits of legislation. Again, this is a detailed slide that you'll have in your pack, but it's just a very simple way of understanding the eligibility criteria for the Care Act. So I'm not going to go through it in detail, you might want to have a look at it afterwards, but it's pretty likely that if somebody has support needs and they're living on the street, that they may well be eligible for adult social care. And it's really worth looking at that if you're advocating and supporting people. And in London, which has 32 local authorities, there's often quite a lot of argy-bargy about between local authorities about ordinary residence and local connection. So in a worst case scenario, a local authority might say that somebody has needs, but actually they are not responsible for meeting them, it's somebody else, because that's where their local connection is for housing or their ordinary residence is for adult social care. Really important to know that the local authority where the person actually is has a duty to assess, and if the needs are evident, they also have a duty to put in the services and then figure out afterwards who has responsibility for paying for those services. And there's a couple of really good resources on the Voices of Stoke website, which is about constructing a Care Act needs assessment with the individual themselves in a way that addresses the issues of multiple exclusion homelessness. I'm getting close to the end now, by the way, so just to let you know that. Another challenge really is working out for practitioners, is working out, do I raise the needs of the person I'm supporting as a safeguarding issue, or do I ask for a Care Act assessment? And again, that's not always straightforward because they are two different pathways. I'm going to move on to just explain the safeguarding pathway. But if in doubt, ask. So if you're not sure, should I make a Care Act assessment or should I raise a safeguarding concern, then ask, because the individual's needs are paramount and it's up to the authority to figure out how best to support them, not for somebody who's less familiar with all the routes and bits of legislation to try and figure it out in advance. A resource slide here about no recourse to public funds. It is really, really super complicated. And again, you can ask Lambeth for advice if you need it, but there is a national network that has lots and lots of guidance documentation in relation to practice and in relation to COVID. So that's there as a resource. So I'm just going to say a little bit about mental capacity as I get to the end of my presentation. deciding whether somebody, as a frontline practitioner, taking a view on whether somebody has the capacity to make decisions for themselves is a little bit complicated. And it's additionally complicated for people who have lifelong histories of trauma and perhaps acquired brain injury as well. Because people, I can talk a good talk, and yet I might not be able to put into action the talking that I'm doing about a decision that I need to make. And when you see over time somebody who says that yes, they will do X, Y, and Z, but then you find them not doing it, and you know that they have a history of trauma, or perhaps they've had brain injury, then actually you need to think about, are they able to act on what they're saying? And you need to get clinical advice on that, because it may be that they don't have the capacity to make the decisions that you're asking them to make, where to live, what to do. And then there is provision in law for the state to make decisions in their best interests. And it's a process, it's complicated, but it is really important to be able to do. And it was an issue with the sad death of Mr. A, in that the view was taken by a number of practitioners that he was choosing to stay out on the street in the snow. And unfortunately, that decision contributed to his death in the moment. And it might have been possible, you can never really say with 2020 hindsight, to have followed a different route and to take a view that he was not making decisions with mental capacity. And just to remind you that if we ourselves cause harm to somebody who lacks the mental capacity, then in certain circumstances we too can be prosecuted. If we believe that somebody who's homeless has had a very serious event or dies as a result of neglect or abuse, then we absolutely must ask for a safeguarding inquiry to be undertaken. We must raise that as a safeguarding concern. And an option that we have in obviously within institutional protocols is to make representations to the coroner's office as well. The Office for National Statistics is working with the coroner's offices across England to make sure that the circumstances of the deaths of rough sleepers are well understood and well inquired upon and well documented. And if somebody's being looked after within the NHS, then we also have powers within the guidance that's available to the NHS to request that they review the circumstances of the death. So if you're concerned about the death of somebody who was rough sleeping, then there are a number of different routes, the safeguarding being one that is significantly important to follow through. So just as I finish now, a number of resources and publications. So they're here, you can dip into them. I've talked about them. Lots of statistics, groundswell talking about lived experience, an e-learning program that Health Education England have done on homeless health. It's not on, there are safeguarding ones as well, but this one's on homeless health. The really important Local Government Association practice briefing, bang up to date. Work that Voices of Stoke have undertaken that is absolutely geared to people with multiple exclusion homelessness, and a little bit of advance notification that the London Safeguarding Adults Board will be updating their procedures with an appendix on safeguarding adults who sleep rough. The Lambeth Safeguarding Adult Board's website, lots of resources there, and details of the 7-minute briefing relating to SARYE.
So perhaps for Paul, how can we safeguard rough sleepers when they are on the streets and local authorities expect them to meet the priority need requirements? They are often housed when they completely deteriorate.
There is no priority need requirement for supported housing for rough sleepers. The only requirement that we have is that someone is rough sleeping, they have support needs, and they have a connection to the borough. So even if they don't have a connection to the borough, we have safe accommodation we can take them to whilst we safely reconnect them to where they should be. But yes, priority need is for accessing statutory housing, not for supported housing.
Okay, we've got a question here that says, have studies been done to determine whether physical health condition prevalence in homeless people is caused by homelessness or are underlying reasons to becoming homeless? If these conditions contribute to becoming homeless, what, if anything, can be done to identify at-risk individuals and help to prevent homelessness? So maybe for you, Sue.
Yeah. So, I mean, I think the first thing that I want to say is that homelessness is about the lack of housing. So in a way that has to be our starting point, and that's about national policy. It's just that simple. Other countries have found other solutions to social housing, and the state that we're in is a very challenging one. There's no doubt whatsoever, though, that if you have health problems, they get worse if you become homeless. There's a range of health problems that might predispose you towards homelessness, and they're all the ones that interfere with your ability to maintain income. So once your income is compromised, your ability to pay for your housing is compromised as well. So you know, mental health problems are significant, but equally physical health problems. You know, somebody who needs to be able-bodied to do construction work and has an industrial accident, ends up without income, is on a road to homelessness. So of course, the health service has to be very alert to people whose physical health and mental health needs are changing. But the dilemma for health and social care practitioners is that access to housing is very challenging.
Yeah, I'll just add to that, Susan, which is to say that in Lambeth, our welfare benefits service, Every Pound Counts, really does an incredible job supporting people to get the benefits that maybe they've been wrongfully denied. And I think when we've looked at some of these cases, often, you know, they have resulted in homelessness, and it's been very, very tragic to see that, because that's often about their difficulty in navigating the benefit system. So, I mean, Sean, perhaps you want to say a bit more about this, but Lambeth really has been advocating and working quite closely with the Department of Work and Pensions to try and improve the systems there to prevent that from happening. Sean?
Yes, and thank you, Jonna. And I should mention in Dispatches, Julia Harrison, who's done some amazing work in Lambeth. She leads the Every Pound Counts team and was instrumental in lobbying the boards, the Safeguarding Adult board, some years ago for some help in getting the DWP to have a better understanding of safeguarding vulnerable people with care and support needs. And of course, we know everyone who's homeless can be defined as having a care and support need as well. Even if they choose not to engage and have the capacity to choose not to engage, we still have a responsibility collectively as those people working both in the public sector and in the community sector to support them to live lives that are free from harm, abuse and neglect. So we've done an awful lot of work with the DWP. I'm now leading that work nationally with the DWP on behalf of the Safeguarding Adult Board chairs nationally, and this has resulted, this I think partly in the dreadful case of the gentleman who died some years ago, about a year ago. His name is not at the front of my head at the moment, forgive me. But the DWP have also appointed safeguarding leads in all their regions now. And all the boards are working with those safeguarding leads to make sure that we have an in terms of DWP policy around safeguarding and training, importantly, training of their staff Jonna and I and Julia have a conversation after this meeting, in fact, with DWP, with the lead trainer, to talk about that very thing. So there's an awful lot of work going on. So we're not just a group of the great and the good that sit around a table and discuss reports. We actually are doing some fabulous work, thanks to the support of Jonna and Julia's officers who work full time to get this together.
It sounds as though Mr. Yee and Mr. A were not well served by the current arrangements for helping homeless people. I don't know the details of the case, but I wonder whether there's an argument for extremely vulnerable people to be classified as high risk and fast tracked through the system to obtain accommodation.
Can I come in there as well, Jonna? So if I go first of all to Mr. Yee, Lambeth was absolutely the best local authority in doing what it did to support Mr. Yee, because actually when he was admitted to hospital in the borough, Lambeth discharged him from hospital into a residential care home where he lived until he died. So Lambeth was recognised as having done the right thing by Mr. Yee. The issues in relation to Mr. Yee have been well accounted for in the learning facilitated by Fiona Bateman, and that all that information is published and online, and that's about ensuring that those who provide homelessness and accommodation services are aware of safeguarding and aware of the need in particular to engage with adult social care at the appropriate time in order to ensure that someone is safe and protected from harm. So I won't go into that now, but suffice to say that that learning is there, and all four boroughs that were engaged, that was Newham, Islington, Hackney and Lambeth, have all kind of done that piece of learning together, and it continues. In relation to Mr. A, that was some time ago, and Susan knows this better, so she'll comment. But I'll say one thing: the Lambeth Safeguarding Adult Board brought the Safeguarding Adult Review of Mr. A back onto the agenda. I think it was 2013 that it was written. Brought it back onto the agenda in 2018-19, so that we could look again at the learning and say, would this happen again in Lambeth? And you know, the conclusion was, we actually are not, we can't commit to say it wouldn't, but what we can commit to is to making sure that that learning is refreshed in the minds of all those practitioners and organisations. And to that end, we've undertaken several pieces of learning, masterclasses. This masterclass is part of that as well, to make sure that that learning continues. I don't know whether Susan would want to add.
So just to add to that, in the aftermath of the publication of the Mr. A review, colleagues in Lambeth had been working across London and with the Greater London Authority on the issues of the implementation of the Mental Capacity Act with rough sleepers. And that led to the publication of a toolkit, or the development of a toolkit, and the publication of a toolkit which is still available. Actually, I didn't put it in my resource. It'll be in the, if you we can add it.
We can send it out.
Yeah. So it's a guide, if you like, to how to apply issues of the Mental Capacity Act in relation to rough sleepers. So again, of course, it's like painting the fourth bridge, as the the metaphor goes. You just have to keep at it all the time, refreshing and reminding people about the issues. But maybe while I'm talking about the Mental Capacity Act, I can pick up a couple of the questions that relate to that. If you need institutional or personal advice, then do talk to Lambeth colleagues, because the devil's always in the detail around these issues. The Mental Capacity Act did create provision for particular individuals in a care context to be prosecuted if they were neglectful or abusive of people who lack the mental capacity to make decisions. So it's very specific. And there have been some test cases that have gone through the courts, some successfully, some not. But in addition to that, any of us who are public servants or registered professionals with any of the registered bodies can also be sanctioned or disciplined if we neglect the needs of somebody who lacks the mental capacity to make key decisions. So if you like, the law has been strengthened, and the regulation has been strengthened. And what that means, I think, for us, all of us as frontline practitioners, is as best we can, we should have confidence to advocate very, very strongly if we believe that somebody isn't able to fully make decisions for themselves, because the weight of the law then protects them, and we have to find a way of engaging with that. I also saw a question on the chat about people who don't have capacity to make decisions but want to return to street living, and whether that could ever be a best interest decision. I mean, obviously the detail of any case would have to be very carefully thought through, but in my own view, it can never be in anybody's interest to live on the street, because the dangers to their physical and mental well-being are so high that you'd have to say no. But if somebody has been detained, so don't have capacity, are being detained under the provisions within the Mental Capacity Act, then there's a duty on the care providers to be as innovative as possible about how to support their care package. So this is just an anecdote, but I know from another authority where I worked, where the individual was allowed to live in their tent in their care home room. Now, you can imagine that would really wind up, potentially wind up the providers. Are they going to get sanctioned by the Care Quality Commission or whatever? But the individual was enabled to create enough of a den in their care home room, and that helped enormously. Now, that isn't going to be right for everybody, but if we're using the legislative powers to detain somebody against their wishes under the Mental Capacity Act, then we have a duty to be as innovative as possible in how we support the care package. And it might be trips out. It might be trips out to the street, you know, with all the kind of health and safety awareness. But just coming back to some of the practice guidance that came out in the LGA toolkit, multidisciplinary reviews of individual circumstances are just so important, because sometimes it's a family member, sometimes it's a care worker or a support worker that's got close to that individual that really knows the thing that will help, and trying to craft then the support plan to help people, just so important.
Yeah, thank you. I'll pass to Sian.
Can I follow that? And there's a descriptor. It's a bit of jargon to that last piece of information that Suzanne shared, and it's called contextual safeguarding. And what that's about is about absolutely ensuring the right person with the right set of skills, and sometimes it just might be the right personality to engage with an individual, is enabled to do that in a formal way that's then recorded in their care and support plan. So it's really important to mention this. And I also really welcome the examples that Suzanne has given in relation to those innovative ways. Many years ago, I used to be director of care and support in a housing association, and I can cite examples of when we enabled people we supported who engaged in very risky behaviour, not necessarily living rough sleeping, but where they were supported to engage in a more safely way in that type of behaviour of choice. So those things are so important. So and for all of your, I mean, I don't know who's on this webinar, but for everybody who's out there who's a frontline practitioner, talk to your line managers about how you can support that, and make sure that it's written down in a plan that explains the risk, that shows how you can mitigate the risk safely, and shows how you can work with the individual to give them choice, even when they have fluctuating capacity, because that's important also to recognise what they would have chosen to do had they had capacity to make that decision at another time. So it's really, really important that you take account of those issues, and it's very heartwarming to hear those examples that Susan gives.
It's sort of also linking into, I suppose, mental capacity. If an individual refused to engage in their tenancy obligation and likely to be a risk of homelessness, where does safeguarding stand on that? So I know, and I can certainly say a little bit about that, which is that Paul and I have done a bit of work around this, and recently drafted some guidance for providers, housing providers, to say in the first instance, if someone is at risk of homelessness, they're not paying their rent, they're not adhering to their tenancy obligations, actually they may not proceed with an eviction, and they must raise a safeguarding concern so that we can have a safeguarding meeting, come together and understand what's going on for them. So we consider it a safeguarding issue, and we would recommend that safeguarding concerns are raised in those situations so that we can better understand what's going on for that individual. I
just want to add to that we've had in place for as many years as I can remember now, an evictions and abandonment protocol, which all of our supported housing providers have to follow before they can proceed to an eviction. Most often, we are able to find an alternative solution to eviction. We do have some people who are very, very difficult to deal with, and whose behaviour often causes them to be at danger of losing their tenancies. What our supported housing providers are very good at is identifying that early on, and then coming to an arrangement with one of the other supported housing hostels or providers that they'll maybe do a bit of a swap around. And rather, if someone's not thriving in one environment, we might try them in a smaller environment with less support. We might try them in an environment that's got a lot more support, or different types of staff members, or a different area. Just so we keep on trying with lots of individuals. Eviction is the absolute last recourse for us, and it's most often when most often happens when it's down to serious criminal behaviour or serious assault, and when unprosecutable offences, that can be an example of when someone may lose their tenancy, but we work very, very hard to prevent it.
So Susan or Paul, with reference to the misguided perception from some that rough sleeping is a lifestyle choice, if a person lacks capacity due to brain injury, do you think it would ever be considered to be in a person's best interest to sleep rough? So, for example, I have a case where a person is deprived of their liberty for their safety in a care home due to lack of capacity, however constantly asks to return to his previous lifestyle of many years duration.
So I guess I've kind of answered that. Personally, I can't think it's, I would never say it was in somebody's best interest to live on the street. And so innovation to support, as we do for people with dementia who want to pursue things that they would have formerly pursued, we accommodate, we find ways. It's a challenge, but practitioners are good at innovating, and people's own personal networks might know what a peer advocate for that individual might be really helpful.
And I would just add one thing from a social work perspective as well, that sometimes people are asking for something that may be what they think they might want, and actually maybe what they just want is a bit of attention and a bit of a diversion to doing something else, where they get some one-on-one that makes them feel good about themselves. So it's good to look at different ways, different diversions and different ways of supporting somebody. Jana, may I just, I know a question came up in the chat kind of early on, and it was in respect of what do we do, because we've referred to the Lambeth Adult Social Care Contact Service, and we've been told that that this person is homeless but doesn't meet the criteria because they have capacity and what have you. I would just say to people, not as a general rule, but but if you are really concerned about somebody, that they need to be protected and safeguarded, and you don't agree with the initial decision you've been given, then please escalate it. It's really important that you don't just accept it if you think there is sound evidence to make other decisions. And so what you should do in that case is contact the Safeguarding Adults Board on the email address, and that will be picked up by Jana and Kerry, and they will go back to the team. You may be able to offer some more information that may enable the team to make a different decision, but it's really important that you escalate it so you don't feel that one response is perhaps not the right response that you should have been given.
Hi Paul, my questions is not on supported housing, but those who are eligible rough sleepers who need either emergency accommodation or temporary housing placement to prevent hospital street discharge. It is a tooth and nail fight to get placement for them to recuperate. Local authorities often pull out the priority needs card, which is inconsiderate of those who are being discharged from hospital or released from prison, which often leads to unplanned readmissions and reoffending.
Okay. We recognise the fact that there has been a history of problematic relationships between hospital discharge teams and housing needs teams. Over the last year or so, we've tried different ways of approaching that. For instance, last year we put in place for a full year a hospital discharge navigator who's working across all the hospital teams to try and identify those who would maybe have more problematic release plans so that we could start sort of planning for them in advance. And what we learned from that was what we really needed was someone embedded within housing options. So we now have a full-time hospital discharge coordinator who works in housing options, who should be working across all of the homelessness teams in hospitals to try and identify early on potential people who are going to be discharged. Which I think that's been the major issue for us, that quite often we get a call on the day, maybe Friday afternoon is the typical example of someone who needs to leave hospital that afternoon, and what have you got for them? And then everyone's scrambling around trying to find something. I mean, as for pulling out the priority needs card, I would hope that you would get a more nuanced response than that from our housing option service, given the fact we have the Homelessness Reduction Act in place, and we have a statutory duty to assess everyone and offer them accommodation for an interim term whilst they're having that assessment. So, I mean, I think the key message, though, is hospital discharge person within housing options, I would hope, would help you to do some more better future planning for some of your discharge clients. But certainly, by all means, contact us if you're still finding any issues with that.
Why is ordinary residence an issue for a Care Act assessment if they are in a hostel?
It's less of an issue. The issue is more rough sleeping and hotels, where people have just pitched up in Lambeth recently. Is that fair, Paul? Yeah.
I mean, it was an issue that we hadn't really anticipated, that Care Act assessments would be required. So I think there was a bit of a scrambling around, but we have got a joint social care, public health, housing, commissioning steering group that was looking into all of that sort of thing. And I think we've established what our duties are in terms of providing Care Act assessments.
What are the key messages for children practitioners, i.e. preventative safeguarding in this area? Or is this just an issue for adults? And how can we prevent young people entering a cycle of homelessness in later life?
Well, I mean, it definitely isn't an issue just for adults. So if you're a child growing up in homelessness, then sadly, you're being prepared for many challenges in your adult life, because the austerity and the difficulty that you face and your parents' anxieties are having a big impact on your formation. And of course, we know that young people who are, in general, in local authority care are overrepresented in the adult homelessness cohort. So what we do to support children and their well-being is just so very important. And of course, we've got young family breakdown, and of course, COVID may exacerbate some of that, which means that some teenagers are coming into homelessness because they're unable to continue living with their family, and for reasons of overcrowding and all sorts of other issues. So for children practitioners, anything that can be done preventatively is just so important. But Paul, you work across both, so.
Yeah. I mean, we have again a pathway of around about 230 beds for young people aged 16 to 21 who find themselves homeless, and we commission a further 140, 150 beds of spot purchased accommodation for looked after children and care leavers across various boroughs in London. It's constantly evolving. We are constantly looking at what we can do to be better at prevention in the first place, about how we can, where it's appropriate, safely reconnect young people back home and then provide them support to stay there rather than just sort of sending them back home and waiting for them to come back again. So, I mean, young people are very, very underrepresented themselves in terms of rough sleeping numbers. The numbers of people under 25 who are rough sleeping in London has spiked a bit, but I would suspect a lot of those were the COVID-related job market cases that Susan mentioned earlier on. But in general, in Lambeth, very, very few people under the age of 25 are rough sleeping. So it's the later in life ramifications for people who have been in care and have experienced chaotic lifestyles when they're growing up. That's the bit that we need to keep on working out how to tackle, and it's a difficult issue. It really is. I mean, from our point of view, I think we are trying to, at the moment, pull together one of the biggest needs assessments that we've ever done for young people's supported housing, and we're in the middle of it at the moment. And Sophie, who is the commissioning manager for young people who works in my team, has been out consulting as far and wide and speaking to as many people as possible about what else we need to do. So I think if anyone else out there who feels they would like a voice in how we look at our young person services, please contact me, because we'd welcome anyone else's points of view.
There have been reports on New Night of unregulating housing for young homeless people. Is there anything being done to address this? Yes.
We have the whole of the semi-independent living, as it's called, which is what the accommodation used for care leavers and looked after children. The whole industry is unregulated. I think we've been quite vocal in stating that we feel it should be regulated, and we would welcome regulation. The ones that we have a framework of providers that we use, and we throughout the year have carried out really, really extensive audits, far above and beyond what Ofsted would audit them for all of our providers, and we've had follow-up visits with them, improvement plans where they're needed. We've identified some of our providers on the framework are really, really good and really thorough, and some of them needed some work. And in one case, there's one of them we decided wasn't acceptable, and we removed all the young people from their services and don't use them anymore. So I mean, we are being as vigilant as we possibly can with that sector, but it needs regulation. It's simple as that.
Thank you very much, Paul. I'll hand over to Sian to conclude.
I just to follow from Paul, it's really gratifying to hear all of that, Paul, and again gives me, although I don't chair the children's partnership in Lambeth, I only chair the adults one. One of our priorities is around transitions of children in need into adulthood and safeguarding there, and it's really provides me with a lot of assurance to hear you say those things. So well done to you and your teams again. I'm sure that a lot of other local authorities nationally could learn from what you're doing.